If you want me, we can start.
Okay. Hey guys, I'm going to be doing the afternoon report today. So the chief complaint of my patient, there's a 66-year-old male. They presented with 2 weeks of progressive dyspnea and hemoptysis. So for his HPI, he presented with 2 weeks of shortness of breath. At first, this dyspnea started with exertion and then progressed to at rest. And then 2 days prior to admission, he also endorsed like associated pleuritic right-sided chest wall pain, a non-productive cough, and 1 episode of hemoptysis. The hemoptysis was like scant, less than a tablespoon. At that point, he actually had an outpatient cardiologist appointment, and he had a chest x-ray done at that time. And the report, according to the patient, was right lower lobe opacities, and told to come to the ED. Of note, he actually had COVID a year ago and has had multiple admissions for hypoxic respiratory failure since then. And then as of 3 months prior to this admission, he was placed on a long steroid taper. In addition, he actually was admitted 3 weeks prior to this admission for hyperglycemia in the setting of this steroid use, and he was discharged 4 days later.
Okay, so before we move forward, do you guys have any questions for Tyler?
What other past medical history does he have besides anything listed here?
Yeah, I can show it on the next slide. So he had uncontrollable diabetes. I believe his last A1C was 9 something, hypertension, hyperlipidemia, CKD, HFrEF. His last EF was about a year ago, but it was 35%. Essential thrombocytosis, paroxysmal AFib, and then this long COVID that he had.
Is he getting any other treatment, especially with the long COVID, or is it just that one steroid taper?
It was the one steroid taper. So he had COVID for about 6 months, and I think there's 2 or 3 admissions at that time. And they actually did PFTs on that. They couldn't really find a cause. So in December, they placed him on a steroid taper, and it was prednisone 60 at the time. The patient presented during this admission like the 3rd week of January.
Any treatment for the essential thrombocytosis?
Yeah, they're just on daily aspirin. And they're on Eliquis for the paroxysmal AFib.
Okay, so maybe we can show more information.
Perfect. We went over the past medical history. There's no past surgical history. The only things in the family were the ones that he knew of. His father was CAD and diabetes. He was unsure of his mother's medical history. In terms of social history, denied current alcohol use. He was a previous smoker, quit 5 years ago, but had a 40-pack year history and never any drug use. He had quite a long list of medications. Currently, his steroid taper at the time, he was on prednisone 30 milligrams daily. He was on a few cardiac meds, Bumex, nifedipine, Coreg, hydralazine, and spironolactone. He was on the aspirin for the essential thrombocytosis, the Eliquis for AFib, and then Lantus. And then he had no known allergies.
He was asking in the chat, is the dyspnea rest now? Is it when sitting up, lying down?
There was no positional changes. It started when he could walk about like a block or so, and then the dyspnea would come about. And then right at admission, he could barely get out of bed without feeling short of breath. But at rest, laying down, he actually felt pretty fine.
Also asking if there's any chest pain when walking.
No chest pain when walking. Just this right-sided chest wall pain and like the right axilla that was worse with inspiration.
Any fever, night sweat, or weight loss? Nobel is asking.
No fever, no night sweats, no weight loss.
Homelessness or incarceration, guys. Where I like all these questions. Where are you getting to?
None of those.
Emily, why are you asking about homelessness or incarceration?
Just, I mean, it's probably for the same reason for the fevers, night sweats, and weight loss is potentially TB.
TB, it's important to consider also because of these symptoms. Homelessness, incarceration, also work in the hospital or a nursing home can be a risk factor. Recent travel, these are all things that are important to us.
Yeah, no recent travel. In terms of occupation, he was like an office worker for a plumbing manufacturer company.
Do you get the sense he was compliant with his medications?
Yeah, he was very healthcare literate. Had a full list of all his meds and knew exactly like his steroid taper that he was on and like all his physicians.
I would just say this would be a very unusual presentation of TB to all of a sudden become so short of breath within a matter of a week. So I would put that high on my list.
And they're asking, I might have missed this. Did he get any antibiotics for the prolonged steroid use? That's a great question.
No, actually, not in the last month or so.
Usually when you're getting like prednisone, do you guys know when you should start like a prophylaxis? PCP, perfect. PCP prophylaxis. Do you guys know when you should consider starting that? Like Bactrim, yeah. So it's technically it's like if you're doing 20 milligrams or more of prednisone for more than a month, that's already kind of an indication to this. And Dr. Prigolin, correct me if I'm wrong, but that's what I remember. So I mean, this guy has been on prednisone forever, which is a little bit awkward.
It was, so I think he originally was on Bactrim prophylaxis when he went to his cardiologist appointment like 5 days prior to admission. He was on prednisone 20 at that time. And then the cardiologist actually put him back on 30. As it was unclear why, but that was the idea.
Okay, that's interesting. And then Nadim was asking, is he a plumber?
I think like 15 or 20 years ago he was, but he's been like an office worker since then.
I don't have any other questions. Oh, no edema of the legs?
Like trace, bilateral. Any more questions? No? Okay. In terms of review of systems, it was positive for just generalized fatigue that got progressively worse since prior to admission. In terms of cardiovascular, he had the dyspnea on exertion, he had that pleuritic right chest wall pain, but there was no substernal chest pain, no palpitations, no orthopnea, no paroxysmal nocturnal dyspnea. He was positive for dyspnea. He had this non-productive cough, and he had that one episode of like scant hemoptysis. The rest of his review systems was benign.
Nadim is asking, any issue with swallowing?
No.
What are you thinking, Nadim?
I mean, just because it's a right lower lobe, consolidation, on review of systems, I would explore to see if this is a potential aspirator.
Yeah, that's a good thought.
Also, I mean, this patient is probably not immunosuppressed that much, but even, esophagitis.
Yeah, no history of seizures or alcoholism or anything like that.
What about his physical exam?
So for his physical, in terms of vitals, he was afebrile. Respiratory rate was 20. When I saw him, he's 90% on 6 liters nasal cannula. I put him on a non-rebreather and he went up to 95%, but just looking at him, he was comfortable. He wasn't really using accessory muscles at all. But in terms of the rest of his physical, he did have this tenderness to the right chest wall, like anterior axillary line, probably around like the 10th rib. In terms of his lung exam, he wasn't using accessory muscles. It was dull to percussion on like the right lower lung field. He had some roncorous sounds as well on the right base side. Abdomen, skin, and neuro were unremarkable.
Any questions? Otherwise, we can move forward with the problem representation. So who wants to give that together the most important things? So otherwise, I'm going to have to volunteer.
I can try. Okay, so we have a 62-year-old male with past medical history of like diabetes, hypertension, and hyperlipidemia, CKD, heart failure with reduced ejection fraction, essential thrombocytosis, AFib, who presents with 2 weeks of shortness of breath that was originally with exertion that now it's like a rest. And he also has like progressive kind of like pleuritic chest pain on the right lower area and a non-projected cough and 1 episode of like small amount of hemoptysis. What else? And then past like social history, he's a former smoker. And on physical exam, he was found to be like on vital signs, he was like hypoxic. And on physical exam, he has tenderness in the right chest wall. He has the rhonchi on the right lower lobe and dull percussion also in the same area. I think that's it.
Great memory. You remember a lot of details.
Yeah.
No, I was taking notes.
No, but still, absolutely. Yeah. So we have a middle-aged man. We do a proper representation. It's important to pick from the past medical history the things that you think might contribute to the current presentation, and try to maybe add those information that can be helpful. And you picked a lot of the important ones. CKD, maybe he has shortness of breath because maybe it's worsening of his CKD. Diabetes, it's uncontrolled, so that's something we might want to add because he just got in the hospital for that. But then other important cues. So he's coming with some hemoptysis. So as you said, so he's taking medications that can increase the risk of hemoptysis. So definitely he has ET on aspirin, AFib on anticoagulation. These are all the important things. And then the time frames, kind of subacute worsening dyspnea, as you were saying, coming with the hypoxic respiratory failure, and these world field findings, as you said.
I think it's important to include in the problem representation that he's been on high dose steroids for a long time, because that's a key part of it.
I'm not sure yours, Tyler.
Yeah. So this is mine. I kept it brief, but it's a middle-aged male with a past medical history of AFib, on anticoagulation, uncontrolled diabetes, long COVID, on steroids, myeloproliferative neoplasm, on aspirin, HFrEF, presenting with subacute dyspnea with minimal hemoptysis. Exam was notable for hypoxic respiratory failure, asymmetric right lung dullness, and roncorous breath sounds.
I guess before we move forward, okay, Lenise is asking, is long COVID an actual diagnosis? Well, that's a great question. I mean, we've been talking a lot about it. I don't know if there's like an ICD code for long COVID yet.
The CDC and like WHO now recognize it, and now it's called post-acute sequelae of like SARS-CoV-2. But it's a very like non-specific findings of dyspnea and fatigue after like an initial COVID infection.
I would just make a brief comment. I think this is a great summary statement of pulmonary representation. I insist with the idea that steroids, to say only that he's on steroids is not good enough for me. I think the high dose and many weeks counts, because it's not the same, right, to be, for 1 week than to be for 3 or 4 weeks. And just, Patricia, just to pay attention to the difference between this statement and yours, just pay attention that Tyler is saying middle-aged man or male rather than 63-year-old man. And he's also saying subacute onset of dyspnea, this or that, rather than repeating 63 years or 2 weeks of. In the pulmonary representation, we'd rather use categories rather than, the same numbers that we just heard. I think it makes, your mind to go through the files of conditions that would present, in young people or elderly people, diseases that present acutely, subacutely, or chronic. Our brain does, that trick. It starts thinking of diagnoses that we associate with those words like subacute.
That just helps you, when you put it together in your note, kind of like start thinking, okay, the time frames and where am I putting this patient, which kind of like diagnoses, I would say, like the clinical problem solvers are all those diagrams. You can start putting those diagrams in your mind and thinking which one's going to be the right one for this patient. And I think before we move forward and, discover more things, I just wanted to quickly talk to you about hemoptysis. And just because I think this is not something we see a lot, it's not a very common, representation and presentation of the patient, but can be traumatic. So we really need to pay attention. And I was actually expecting more questions of you guys about the hemoptysis of the patient. I think I did a great job of quantifying it and telling you it's a minimal amount. But that's something you always need to have an idea when you have someone that tells you, I have blood in my sputum. That can be nothing, can be a lot, big deal. So that depends. We define.
But also just point out before you do that even though we said this is subacute, it does seem like there was an acute worsening in the last week where something changed. So it wasn't just a subacute presentation. There was a subacute presentation, then all of a sudden something shifted. At least that's what I got from the presentation.
Yeah, looks like he's getting quickly much worse. Went to his cardiologist. The cardiologist, I didn't know how he didn't tell me that the cardiologist started to put like the steroids back up. That was like interesting to know.
Yeah, strange.
Absolutely. So hemoptysis, you guys know, it's a bleeding from below the vocal cord, so lower respiratory tract. So that's the only thing that we define as hemoptysis. And just for you guys to have an idea, and I mean, you already know this, there's 2 different systems in the lungs. We have the bronchial artery and the pulmonary artery. The bronchial artery is high pressure because it's coming directly from the aorta. So whenever you touch that system, you're gonna have massive amount of bleeding. You can have life-threatening bleeding and hemoptysis because it's an artery with high pressure, a lot of blood going there. We all know it's the oxygenated blood coming from the heart, very low pressure, very low resistance. So when you tackle that, most likely you're gonna have non-life-threatening hemoptysis because the amount of bleeding is small. Just for us to have an idea of why some patients get worse and some patients just have some streaks of blood in the sputum. And we need to differentiate pseudomoptysis. Do you guys know what that means? Or let's say a patient is telling you, hey, I have blood in my sputum. What do you ask to be 100% sure this is actually hemoptysis? And center in the ED, wherever you are. Okay, so you need to make sure that that blood is actually coming. Yeah, it's tricky, absolutely. How much is it? And like, how does it look like? But you need to make sure that it's actually coming from the lower respiratory tract. So you need pseudomoptysis means fake hemoptysis, right? So the most frequent cause of fake hemoptysis is GI bleeds, because that's much more common. So for example, patient that's vomiting and then they come with the blood, maybe this is coming from the GI tract and it's not really coming from the respiratory tract. Big difference, totally different treatment, risk of bleeding and hemorrhagic shock different. So that's really important to have an idea. Second possibility, upper respiratory tract bleeding. So anything coming from above the vocal cords, so epistaxis, even scratching of your throat can cause sometimes some streaky blood. That's not really hemoptysis. So gather a good, history from these patients. And then this is probably going to give you PTSD from step 1, but you do have that current jelly sputum in your stem of the question that tells you the patient actually has Klebsiella pneumonia or serratia. So those pneumonias that cause that red sputum that is not blood. So those are the most common causes of pseudomoptysis. So step 0 when you see these patients is this real? Okay, so evaluate for these options. And the causes. I mean, there is no study right now that tells you 100% the percent of different type of hemoptysis. This is taken from a study done in France. If you go to UpToDate, it will tell you that 30% of the patients have cryptogenic. This study showed that 50% of those patients had cryptogenic. So most of the times you actually don't know what's the hemoptysis cause. But then very frequent causes can be infection, your bronchitis. And this is because when you have bronchitis, anything that causes inflammation of the bronchus, the wall is going to be fragile and some of the arteries or the capillaries can break off and you have the blood coming out. Of course, lung cancer, bronchiectasis, so patients with cystic fibrosis or chronic damage to the lung. And bronchiectasis can be very dangerous because sometimes the damage is so much so that the bronchus is so dilated, so eroded that you get to a bronchial artery and you have massive bleeding. So that can be a very high risk of hemoptysis. But we all study this from our steps, pulmonary edema, so advanced FRF, mitral stenosis. You have all the congestion of the vessels of the venous system, the pulmonary venous system, that some blood is spilling out from the pulmonary arteries, from the capillaries. So that's why it's not a lot of blood, it's just streak, it's the low pressure system. And then other causes, use of anticoagulation, TB worldwide, probably the most frequent cause of hemoptysis in all the world, PEs, and then also other less common causes, vasculitis. Think about the catamenial hemoptysis, super rare. So that's someone, it's a woman has endometriosis in the thorax. So recurrent with the menses, she has some hemoptysis. Very rare, but that's a possibility. Okay, so now, what to do with patients? We already went over the step 0, rule out the fake hemoptysis. Step 1, extremely important, quantify. You need to know the amount of the bleeding and why. So the lungs are not like the GI system, like they cannot take in a lot of blood. Even a small amount of blood in the lung will close it up and you will not be able to breathe at all. You will lose lung to the blood. So you need to know how much the patient is bleeding and differentiate submassive versus massive hemoptysis. Again, there's no consensus of how much is too much. In general, more than 100 cc a day is a massive life-threatening hemoptysis. And 100 cc is a cup. It's like nothing. And that's because of what we were saying. The lungs cannot really take in a lot of blood. So that's important to ask your patients how much you're actually coughing. And sometimes they have no idea. They might tell you a cup, but they don't really know what's a real cup. So it's difficult to quantify. So give them a container. They're coming to the ED, and you tell them you have to cough in here so that you have an idea of how much they are actually bleeding. And the process of massive to massive bleeding can be a little bit different. TB, as we said already, worldwide the most frequent. Bronchitis, very common, just causes a small amount of inflammation. It's usually not that much. While on the other side, if you have things that are invading the lungs, like mycetoma, pneumonia that's necrotizing, cancer, those can cause a lot of bleeding because they totally erode the walls and they can affect the arteries. If you have a life-threatening bleeding, that's ABC all the way. So it's your usual unstable patient. You need to assess the ABC. Let's say the patient is still awake and they can, protect their airways. You use gravity, so bleeding sat down. your lung that's bleeding goes down so that it doesn't spill into the good lung. And usually if you are already a chest x-ray, 46% of the chest x-ray will tell you the site of the bleeding. If you have no idea where it's bleeding, the patient should stay up. Don't ask them to lay down because you have no idea which one is the good lung. And it's very important to look at your patient. If you have a young patient with amazing lungs, you have more time before you want to intubate that patient, because even if the lungs is a little bit lost to blood, the other lung will be good enough to breathe. But if you have an older patient, COPD, and the lungs are already damaged, then that patient may need intubation earlier. ICU team, they're going to decide whether to intubate or not. And there's different techniques to intubate only one lung. Depending on that, you might need different ventilator settings, but that's not something we need to talk about at all. You have this hemoptysis patient, and it doesn't matter if it's massive, submassive, you'll do that regardless. You need to find out what's happening, what's causing the hemoptysis. So it's pretty straightforward. So you gather your history. Very important to think about what's causing hemoptysis. So risk for TB, risk factor for lung cancer, risk factors for PE, what medication is the patient taking? All of these things you should ask right away. And your basic workup, it's usually a CBC, a BMP, the CBC to see for how long they've been bleeding, the BMP to check the kidney function, and the UA also, because you might think vasculitis, and vasculitis affect the lungs and the kidney, so you might want to check that. LFTs, coags, of course, you want to see if they have thrombocytopenia, coagulopathy. And then depending on your, differential diagnosis, sometimes you'll do sputum cultures, AFB, autoimmune workup, BNP if you think this is just coming from the heart. And every patient with hemoptysis will get a chest X-ray. We said 46% of the time that will help you find out where is the bleeding coming from. Have any diagnosis from this first workup? If yes, you just treat the patient. If no, then there's a second step. So there is a situation where you do not do anything, and it's the bronchitis. A lot of patients that will come at WFR and they have bronchitis. Patients with the ED, they might have, the classical upper respiratory symptoms. They have some streaks of blood with their cough. They have some fever. The chest X-ray doesn't show anything. If you do not have any, suspicion for cancer, for other things, depending on that specific patient, you just observe that person. You think this is just a bronchitis. If that will resolve, that's it. The hemoptysis, so the symptoms come back, then you need to do a CAT scan and the workup to see what's happening. Maybe that your patient has risk factors for lung cancer. So, for example, this patient, they're using tobacco. They might have COPD, or other situations where you're suspecting lung cancer. So in these cases, you always get a CT chest. You don't just let the patient go away and you see them in 2 weeks. The type of CT chest depends on what you're suspecting. Usually for lung cancer, you can do a high resolution or a CT with contrast. You want to see also the vasculature. If you're thinking bronchiectasis, you also do a high resolution. So that will depend, and you will talk to the radiology office to see which one is the best. Third option, if you think that the patient has risk factor for PE, so DVTs, malignancy, pregnancy, then you get a CTPA. You don't just wait. You need to make sure that you have no idea. Everything is negative. The patient does not have any specific risk factor, so you cannot just leave it there. You need to do more workup. And usually these patients might get both a CT chest and a bronchoscopy to try to figure out what's the etiology. The times we don't know, because we said 30 to 50% is actually cryptogenic. So, but that's the idea of how you should, approach a patient like this. And even this patient, very important to know how much they're bleeding. And Tyler did a great job specifying that this is just a small amount of blood, but you might want to reassess that when the patient comes to you in the hospital. I think you can continue.
All right. What labs do you guys want to order or testing?
your CMP, BNP, coags, VBG, all good options. What did you guys end up doing?
All right. So we did all the basic labs at the beginning, but of note, he was noted to have a creatinine of 4.0 and a BUN of 80. His baseline creatinine is around 2.2 to 2.5 with his CKD. In terms of his CBC, he had a white count of 40, a hemoglobin of 9.7, and a platelet count of almost 2 million. His baseline platelet count, it tended to be around like 800,000. In terms of coags, they weren't that bad, like upper end of normal. LFTs were fine. He didn't have a lactate. Trope was mildly elevated initially, but downtrended. Is there any other imaging or anything that you guys would look at?
Okay. Lenny Sanchez, it's right. Also the question, do you have a recent CBC?
Prior, I don't have it in the slides, but the admission that was like 3 weeks ago, his white count was about like 18 at that time.
Okay, I'm just asking because with essential thrombocythemia, you can have a higher white cell count. You usually don't have very, very high unless you also have CML,
Yeah.
but because 40 is pretty high, so.
Mm-hmm. And he was good, and he knew that his white count tended to be around like 17, 18. So 40 was high for him when we told him.
Just related to that, like baseline hemoglobin, because I mean, he's on the lower end, and this would give us an idea of how much he was actually producing.
Yeah, he was around 10.
Okay.
The last time. All right. In terms of imaging, we actually, yeah. Let's see, we got a chest CT, and this is what we saw. So I'd ask you, like, one, how would you interpret that chest CT, and what would you do next?
Anybody take a shot.
Something's wrong.
Nasty CT.
And even consult someone if you want to consult them.
Yeah, pulm.
Tonsil pump, that's a great answer. Or bronchoscopy.
All right, I like that answer. First off, we could see it is there is a consolidation there, and there's also, it kind of looks like, I don't know if you can see my mouse, but there's a thickened border within the consolidation. So I kind of want to briefly talk about cavitary lesions and an algorithm. This is based off a paper that I'll reference at the end, and I'll post the PDF in the chat. But the first step when you come across a CT that looks like a cavitary lesion is it a cavity that you're actually looking at, or is it another mimicker? And I'll go through some pictures as well. So this is a common finding, or more common finding with CAT scans. Does anyone know what this is? Yeah, Lenice is right. It's a cyst, and the way you can tell is they're typically very round, and then they'll have a thin wall. And what they define thin is less than 2 millimeters.
I mean, you're not too wrong saying bleb, because it might look like a bleb, like, you know, a bulla, but the only thing is that there's like this really kind of defined wall, but it could technically also almost look like a bleb. So yeah.
Mm-hmm. And then what about this one? Yeah, so this would be more like emphysema. So it can be focal, and then if you notice a difference, you don't actually see the wall border around these lesions. And I have a couple more. How about this one? So with an abscess, you typically see a thicker wall. With this one is you can see blebs, or in this case, bulla, because they're larger, with a thin or no wall, but now they have an air fluid level. So this is more consistent with like an infected bulla. And then this is my last one. How about this?
And bronchiectasis or bronchitis?
Yeah, so this is more consistent with cystic bronchiectasis. And the idea here is you get the thickened bronchioles, but you don't have the bronchial narrowing that you'll typically see. It ends with these like bubble-shaped areas of the bronchi. So those are common or more common mimics of cavitary lesions if you come across a CT scan. The next step would be to assess duration. So the most important thing here is it acute, subacute? And they kind of define this as less than 12 weeks. And then this kind of differentiates what is the etiology of the cavitation. And more common ones would be lung abscess, septic emboli, or invasive fungal infections. In cases of the lung abscess, you think of alcoholics, seizures, people with diabetes. Think of like aspiration risks. Patients usually present with high fevers, foul smelling sputum, and then on the CT, they're usually unilateral. You'll see thick walled cavities, and they typically have those air fluid levels. For septic emboli, think of central venous catheters, any pacemakers or ICDs, histories of IV drug use or prosthetic valves. On the right side, they're usually present with fevers, dyspnea, and they're usually pretty sick and will be septic and can go into septic shock. On a CAT scan, you'll usually see multiple and bilateral cavitations, and they're usually in different stages just because of the shooting off of the emboli. And lastly, for acute, you can think of invasive fungal infections. So in patients who are immunocompromised or have a significant travel history, these patients typically or can present with hemoptysis. They can have positive fungal markers. And then they can be single or multiple. They typically present as nodules. And then eventually, as they progress, they can lead to cavitation. Next to that, if you think of chronic lesions or greater than 12 weeks, you can think of chronic infections. These are typically the ones you can have fever, weight loss, hemoptysis again. You think of TB or MAC, fungal, parasitic. It's kind of a wide category. Next, you would think of malignancy. These would be patients that are older, weight loss, smoking history, cancer history. And then you would go between like primary or secondary malignancy based off number of cavities or lesions that you see. And lastly, the broad category would be autoimmunity. So if they have a history of connective tissue disease or arthralgias or positive serologies in the past or presently, and you can think of rheumatoid nodules or granulomatosis with polyangiitis. And the way you typically assess duration is one, just clinically and based off the history of when their symptoms are progressing. And if you can find old imaging, which is always good. So back to our case. So I was able to look back in his chart. So during his hospitalization, that was like 3 weeks prior, for the hyperglycemia, he actually had a CAT scan of his chest at that time. the documentation wasn't the greatest, but presumably it was for this long COVID symptoms, and he had dyspnea. So the CAT scan on the left is actually what was seen 20 days prior to admission. And you can see kind of this large nodule that it was actually not followed up on during that admission, and the patient didn't actually know about it. And then you can compare that to 20 days later when he presented during this admission, and that small like spiculated like nodule progressed into this large cavitary lesion with consolidation. So in terms of other micro that we got blood cultures. They were negative. BD-glucan was negative. Galactomannan was negative. Urine histo was negative, and crypto was negative as well. When we first admitted him, I placed him on non-rebreather, and he eventually was on high flow. And he was on high flow for about 3 days. Palm was consulted with the end goal of a bronchoscopy. And so they ended up doing the bronchoscopy with a biopsy, and it actually showed irregular branching non-septate hyphae that was consistent with mucor. Sputum cultures actually grew pseudomonas as well on top of that. So at that time, we placed him on broad spectrum like antibiotics. He was on liposomal amphotericin, isovuconazole, micafungin. Thoracic surgery was also consulted at that time. We went back and forth of trying to offer a lobectomy for this patient versus a cavernostomy versus pneumonectomy, with the idea of debriding this necrotic tissue or infection that he has. At that time, he wasn't really a surgical candidate. He had PFTs prior due to this long COVID, and his DLCO was like 43%. So thoracic surgery did not want to take him to the OR. So I was able to follow along in the chart a few days later, but this is kind of the progression of his disease. So on day 24, after this initial nodule that was found at the previous admission, it shows like a larger cavitary lesion with more air spaces in the middle, but the consolidation around it was a little improved. And then about a week later, they repeated the CAT scan, and the cavitation is still on the right side. And now you can kind of see that the left side has a little more opacification. I'm not sure if they're thinking that was invasion of the mucor in the left lung, or anything else. And then lastly, just a brief illness script for like these zygomycetes. These are kind of the textbook antifungals that you think of for uncontrolled diabetes history. Like this patient, he was on steroids for a long time. He had a recent hyperglycemia admission. He actually had a hematologic issues as well. Or they could be with patients status post-transplant, and actually iron overload. These fungi actually like to feed on iron. Clinical features can be plus or minus fever. They can have rhinocerebral involvement. That's the typical like board questions of the necrotic masses and like the sinuses, and it has a really poor prognosis if you have rhinocerebral involvement. You can get the cutaneous lesions with the black eschar, and then pulmonary, as in this patient. And the pulmonary involvement, they're very at risk of infarction and necrosis. So these infections like to invade the blood vessels. So they can lead to actually massive hemoptysis if a large blood vessel is eroded. In terms of diagnosing it, they're BD-glucan negative actually, and usually you need a bronch with a biopsy and histopathology. to get a confirmatory diagnosis. The treatment is debridement if possible, if it's a cutaneous or a sinus lesion. And then if you can't do that, or even if you can, you'd still put them on antifungals like amphotericin, posaconazole, and isobuconazole are the ones typically used. For prognosis, there's a high mortality rate, especially with rhinocerebral and pulmonary involvement. With this patient, we actually got a CT head and CT sinus, and he never had any sinus or cerebral involvement. It was strictly in the lungs. And this is just that the paper that I referenced for the cavitary lung lesion algorithm. And I can post the PDF in the chat. It's very good, and it goes through all the different etiologies and actually shows the CT images to kind of compare them.
Patient like die or?
So as of right now, or at least as of a few days ago, his kidney function got worse, so they had to stop the amphotericin and just continue the isobuconazole and mica at that time. But yeah, the pulmonology and ID gave him like a 95% mortality without surgery. Surgery said he was like an 80% chance that he was gonna die on the table if they brought him to the OR. So we were kind of stuck between a rock and a hard place with him.
I actually found a lot of reports of mucormycosis in patients with COVID or post-COVID, especially if they had diabetes because of the steroids, and like there's tons, like from India, Mexico, like a lot of countries.
Yep, there's a lot of case reports of aspergillosis in COVID patients just because they get put on steroids right away and that.
Although I would define what you mean by a lot of reports,
Yeah.
since there are millions of COVID cases around the world.
Like if you not millions of publications, but there are like quite a few of reports of cases of mucormycosis in patients that had steroid treatment after COVID, especially if they had diabetes.
Again, can you define what you mean by multiple reports? Are we talking
Like
thousands, hundreds, or 10? There's a difference, right?
Yeah.
There
It was interesting because I found them like, Mexico from, like from different countries. That's why I was like, oh, interesting.
in India, at least there, I think the last paper I saw, there was at least about 100 of them.
Well, let's just keep it in perspective with the worldwide number of cases of COVID. This is not something we should start thinking about in everyone that comes in with long COVID.
Yeah. It was actually pretty interesting. This was a patient at Sloan, and I consulted ID on admission when I saw the CAT scan, and the ID fellow was like, oh, this person has hemoptysis, they were on steroids, they had COVID, and this pleuritic like chest wall pain was apparently very consistent with a mucor pneumonia, and that's what it ended up being.
Is that where the original CAT scan was done, that no one kind of followed up on that?
Yeah, unfortunately.
Thank God. I was hoping it wasn't here.
No. Yeah.
Yeah, to me, this is a great case because, I mean, you always go by do no harm first, right?
Mhm.
And it makes you wonder, right? The validity of doing treatments, for clinical pictures that are not clearly defined. Like if I dose steroids for a long time, and somebody who ends up, with high chances of, passing away from this.
Mhm. And one of his questions was, did I have this infection this entire time with his, from what people kept telling him was long COVID, but did he have like mucor? And we're like, probably not, since it's such a fast moving infection. It probably happened they're started a few weeks before that admission, but it's hard to say.
If anything, it seems that the steroids really tilt him over.
Mhm.
So we can blame the cardiologist that increased him by that 10 milligrams.
Yeah.
I like that.
Still crazy that he was like on such a high dose of steroids like for such a long time with no real, and no one got worried about that CT shots initially on like 60 milligrams of prednisone. That's a little weird to me, but
But I'm also not sure there's a lot of good evidence that that really is effective for people with long COVID. People are searching for something to do. You know, without having a lot of evidence, that's what Dr. Prigalini was saying, right? You know, what was the indication to put him on that long course? If you didn't see an improvement, did it really need to be continued or should it have been stopped?